I work with Prof. Mornan at OHDSI Singapore. I am primarily out of the National University of Singapore. I've been with OHDSI for a few years now, and I've been super glad to learn from everyone. I see a lot of familiar names, and I'm grateful to everybody who's been, around to help. Thank you to Mukesh and Erwin for having me on the OHDSI Scientific Forum for today. And I'm really looking forward to having a discussion with everyone. And primarily today, we want to talk a little bit about how we are looking at APAC and or regional databases and trying to see if there are any specific characteristics that may warrant a different approach to working with regional databases. So today is a little bit messy because what I have has been very exploratory so far. And it's going to be reasonably fast because I want to sort of get to the end and open the floor up for discussion for a lot of this, right? So in 2024, we ran the GLP-1 study. Primarily, I was asking, is the use of the GLP-1 drug as a second-line drug for type 2 diabetes associated with acute liver injury? We compared it with a DPP-4 inhibitor cohort. We assessed it via the standard OHDSI pipeline. I'm not going to go into the specifics of that because we just need to know this background specifically for what we're going to discuss today. And so partway through, while we were running the study, we realized that there were some database-related issues. We had a bunch of lovely collaborators. We had 15 cohorts that tried to run the package, and out of the 15 cohorts, only 9 passed. So you can see here that 8 out of 9 North America cohorts passed, but only 1 of the APAC ANZ cohorts passed. Neither of the EU cohorts from France and Germany disease analyzers passed. And so I was a bit like, why? Because the original question came from, in relation to the safety of GLP-1s, was coming from the Health Sciences Authority of Singapore. So if I didn't have enough Asian cohorts, I would have done the study and I wouldn't be able to answer back to the HSA in Singapore in relation to whether or not these results were generalizable. I would know the results for a North American population. I wouldn't know if they would apply to a Singaporean population or even an Asian population, right? So even then, the cohort sizes were already pretty rough. Before diagnostics, the cohort sizes were already small. So even including like all of the 4 APAC ANZ cohorts and the 2 EU cohorts, you can see here that North America was already like 96.8% of the cohort size. So APAC ANZ was already minuscule at best. And this is including Severance, which has like over 100,000 contributors in the cohort, right? So, and they got even smaller after the diagnostics. After the diagnostics, I ran it quick and I was like, okay, like my cohort is 99% North America, even though the question was originating again in Singapore. So I can't generalize it, even if I answer the question. The last 1% came from Japan. Thank you, Japan. So based on that, we know looking backwards at OHDSI that historically the OHDSI frameworks, the cohort method, everything, it was built around North American databases. It was built in North America and centered around North American databases. It was just where it's originated. It's not a matter of like people being racist or regionalist or whichever. That's just how it is, right? And of course, that means that the frameworks are optimized for the large size of North American databases that have a lot of data in it. But what does that mean for the rest of us in APAC or EU or Africa, especially given the context in which we're supposed to contribute to global network studies if our databases keep dropping out of the studies just because our sizes are not enough, just because we are not passing any of the cohorts? That really just means that we're not able to contribute to the network studies properly. So you can see on the screen that we have a table of 15 cohorts and why they passed or failed. The top section is the EU section, the middle section is the APAC ANZ section, and the bottom section is the North America section. And we can see here that pretty much all of the North American databases have passed other than the last one, which I don't know why that has no data. I haven't looked into it yet. And specifically, we can see that for the EU and the APAC databases, we see that they're failing at 2 points. Covariate balance, which is the first one here in the middle. Can I draw on this? Laser pointer. So covariate balance and empirical equipoise I should have got a mouse. Anyway, no cohorts were failing on residual bias, so we good on this one. But it does raise sort of a question for us. I see already there's sort of a few questions like, are North American cohorts just better at handling statistical discrimination compared to other databases? Is it a question of size because the North American cohorts are just so much bigger? Is it because the North American cohorts are more generalized and because the Asian cohorts are more niche, like they're very specific to really individualized specialties? Maybe it's just because they're too small to be able to handle the statistical discrimination. Is it because of the specific question that I was asking with the GLP-1 study? And is this something that I'm going to be seeing in other OHDSI studies? Because once again, like, what does that mean for our contribution as part of the region into the global network studies? Despite our desire to contribute and we want to contribute, we want to be part of, the global symposium, etc. It seems like there's a mismatch between the cohort diagnostics process and the inclusion of non-North American databases in global network studies. So the long-term objectives of this effort are simpler on paper, but they will probably take some time, which is why I withdrew this from like the APAC cohort study for 2026, because I felt like this is not part of the standard package. So the first thing we want to do, we want to conduct a meta study, so a study of studies, ideally with studies that have databases from multiple regions. We want to assess if regional databases may differ from North American databases. So what I've done so far has been, yeah, there might be, but it could also maybe not. Maybe it's just my study. If we find across studies that this is necessary, ideally, we want to develop a set of guidelines, strategies, or frameworks for maybe how we want to be working with regional databases and how this can be contributing to the global network study. Specifically for today's sort of short-term objectives of the presentation, we're going to focus on this first point in relation to the meta study. But we keep in mind the long-term points, which is, again, we want to see if, okay, do we need to change the way we work with the studies? But today's point is mostly we're going to be looking at this chunk. So today's short-term studies, I want to present some preliminary results based on 1.5 studies. And I want to open the floor again for input and discussion for my exploratory methodology, for some access to other studies, getting more people involved. And this is less of a clinical study. I do want to emphasize and more of an analytic study. We do need to understand the clinical background of the studies that we're looking at, but it's definitely more of an, like, again, study of studies type of situation. So these are objectives for today. We are gonna go ahead and get into the quick and messy methodology. All right. So once again, just to clarify, there's no protocol. I was mostly doing basic statistical associations. I was exploring stuff, just trying to dig out, okay, what makes sense, what doesn't make sense. I don't know. And on top of that, it is true that obviously every study has a different way of evaluating their outcomes. They're all slightly different. So I was just winging it the whole time. And also, to be honest with you, I don't really understand the OHDSI statistics sufficiently. I'm sure there are better experts than me. So please, I will ask for some feedback at the end in terms of the methodology, but yes, keep in mind there's no protocol here. Remember that we were looking at why the cohorts were failing at the diagnostic section. So yes, there's outcome. We're not going to focus on it. We're just going to look for now in terms of why the cohorts were failing at diagnostics. We have three main diagnostics criteria for the GLP-1: covariate balance, the empirical equipoise, and ease. Out of these three, a lot of the APAC cohorts were the regional cohorts were failing covariate balance and empirical equipoise. Ease was totally fine, like everybody passed ease. Today, we're specifically going to focus on covariate balance only because I haven't had time to look at the other stuff. And this is already a lot. Okay, so we're going to look at covariate balance. Specifically, we're going to be looking at the distribution of covariates across regions and some observable patterns that I've seen in the GLP-1 study and or the half fluoroquinolone study. And I'll explain later why it's a half. So once again, let's go. Once again, a reminder that this is winging it. So yes, the methods are going to be a little bit like, but please bear with me. So a brief overview on covariate balance for anyone who's a little bit newer, which we shouldn't be, but it's okay. So OHDSI automatically generates covariates and they're grouped by domains, right? Your usual stuff. It's condition occurrence, drug exposure, procedure. And then it uses the feature extraction package as part of your study to define which domains, to define the time windows, and then generate the eligible concepts and select them via regularization regression. Yeah, that's the steps of it. For a database to pass the covariate balance metric, we set a threshold for the ASDM. So for instance, if we set the threshold at 0.1, if a cohort has an ASDM that's lesser or smaller than 0.1, it will pass this threshold. If it's bigger, then it fails. So the smaller the threshold we set, the stricter it is. So 0.1 is, I think, the smallest one that we can set. I don't know if it can go any lower than that. If a cohort is below the ASDM threshold, it suggests that the propensity score adjustment minimizes confounding. So a low ASDM threshold means that we're minimizing confounding. That's sort of the indirect way to think about it. So we work backwards and we interpret cohorts, and we say that if the cohorts are failing ASDM, that means that the database is more likely to have confounding. It's more likely to mess with the statistics, and therefore they are excluded from the study because we can't work with the adjusted confounders. So once again, why did so many regional databases fail the ASDM threshold, i.e., why did so many of the regional databases have so much possible confounding, which means we wanted to go and look at, the covariates for a covariate balance. So we went to set the ASDM threshold at 0.1. For each cohort, I was just looking at, okay, what is the number of covariates? And then for each covariate, and I went to go back and count like the number of covariates. And for each covariate, how much of a cohort is counted for that covariate? Like how many, for that covariate, how many subjects are part of that covariate, right? So what I did, yes, very manual, very sad, very bad. I went to the Shiny apps for the GLP-1 and the fluoroquinolone studies in 2023 SOS. I downloaded the raw Excel sheets. I downloaded the cohort counts, the diagnostics, estimations, etc. I just ran a local script, and we're going to look at the results of looking at that right now. So we're going to look at the results. Quick reminder that we're trying to assess whether or not the use of GLP-1 is associated with acute liver injury. So our target cohort was GLP-1. The outcome was acute liver injury. We're comparing it with DPP-4, and then we're assessing it via the standard OHDSI pipeline. Do I need to slow down? Am I going too fast?
I think it's okay.
Okay. I follow Mukesh. Okay. Just if I need to slow down, just let me know, because I've been told I should slow down sometimes. Anyway, so GLP-1 study. So we have 3 cohorts that we're looking at here. The main outcome cohort, the acute liver injury, the users of GLP-1 drugs, which is the second cohort, and the last cohort is the DPP-4 drug users comparator cohort, standard OHDSI pipeline. So before the diagnostics, here were the cohort counts. Again, this was the number I quoted earlier. We had like a very nice big 9 million users, except like 96% of them were North American. This was a quick thing I did, which was as part of the initial diagnostics, like before the diagnosis, you want to match them based on the propensity score. So you see here that you have the GLP-1 cohort counts for each database, the DPP-4 cohort counts for each database, and then the cohort count after matching. And then I just did this weird thing where like I just took the matched count and calculated it as a percentage of the original GLP-1 and DPP-4 cohorts. So for instance, in the France disease analyzer, right? You can see that the GLP-1 here has a count of 1,863. Whoop. The DPP-4 has about 2,000 something cohorts, but the approximation of the matched users were about the same for each cohort. So it's about 27% to 33%. These numbers, they match a bit, so it's okay. The cohort sizes are pretty similar, so it's okay. And then if you look at the North American databases, most of these match also. So there's a bit of an exception. You have Pharmetrics, you have HealthVerity. The match count makes up a higher percentage of the DPP-4 cohort. So you see the 66 versus the 26 here. There's a little bit of a mismatch here, but then and then there's a numerical mismatch on here as well. It's a little bit wonky. And then if you look at the Asian cohorts, across the 3 cohorts that were evaluated, the match percentages are pretty different as well. So in the top one, in Yonsei's, the match count makes up 23% of the GLP-1 cohort, but only 4% of the DPP-4 cohort. And then if you look at the absolute numbers, though, Yonsei's DPP-4 cohort is 7 times larger than the GLP-1 cohort. So, and then Taipei's DPP-4 cohort is also 8 times larger than the GLP-1 cohort, right? So just from this quick sort of overview, the biggest takeaway here is sort of that, okay, Asia has a smaller GLP-1 cohort, which is fine because Asia has been using GLP-1s for less time than North America and possibly EU. So the cohort sizes of the database are already drowning. This one has no immediate relevance to sort of the covariate balance, but it's sort of just something to keep in mind. I have no idea how to interpret the American differences. If somebody can help me later on, it would be helpful. So yes, moving into the covariate coverage. So again, for each database, we set the threshold for ASDM to be equal to 0.1. And then I just went to manually like calculate, okay, what is the ratio of covariates for each covariate with subject counts If they're under the threshold that I just labeled them -1 or NAN, if the subject counts are less than 1,000, less than 10,000, less than 20,000, blah, 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 or until less than 1M and more than 1M. So for the GLP-1 studies, again, we have 3 cohorts: acute liver injury, GLP-1, and GPP4. Here we are looking at the acute liver injury cohort. So -1 just stands for, again, how much of each cohort has values below threshold. I know it's hard to see. I'm happy to share this slide so you can go and see later. But for each column, each ratio, each cell here just represents how many of that database's covariates counts under that value. And then I just marked in green when they all hit 1, which means that all of the covariates had numbers, cohort counts under this number. So you can see that a lot of it here, this top chunk is in North American. This is North America. This is ANZ, which is a bit unfair to have it by itself because I think the cohort count of that was like 20. And then you have APAC, and then you have EU in this bottom chunk. So you can see here that the counts for a lot of the covariates were in they had quite a lot. They had anywhere between 100 to 500,000, and some of them had under 1 million or even over 1 million, right? But the LPDAU chunk was really small, and then a lot of the Asian databases also had cohort counts were really small. I mean, that makes sort of sense. If your cohort sizes are small, then your covariate is going to be small as well. But just to sort of put it here, then when we're calculating covariate differences, it is very visible to see that it is small. And I just repeated this analysis really quickly over the other 2 cohorts, the GLP-1 and DPP4 cohorts, and same stuff happening. So the next thing I did was I just looked at the covariates and was like, okay, so these ratios reflect what we saw in the manual cohort counts, which makes sense, but doesn't really mean anything. And then I just wanted to see if there were any clusters of patterns. So I did a little bit of unsupervised machine learning because I didn't know how else to do it. If somebody else has a different method, please tell me. So the data set was so big, I just couldn't manually look for patterns, especially if I wanted to replicate it. I did a little bit of k-means clustering. It's unsupervised machine learning. You partition the data set, and then you basically just look for clusters that minimize the distance between points. Is the sort of the layperson explanation of it, I think. So I ran it for each cohort. The one on the left, once again, is the acute liver injury cohort, then the GLP-1 cohort, and then the DPP4 cohort. And then it found 5 different clusters. And then I went to look into the clusters just to see, okay, what do these clusters mean? The bars here just represent the level of missingness, and then each color is representing a region. Again, I will send out the slides so that you can look at this a little bit closely. So for instance, you can see in this cluster that there are 3 regions that they have the information for that covariate, but there's one specific region that just does not have that set of covariates. That's really what this chunk means. And so we found across these 5 clusters, so 1 cluster, 2 cluster, 3 cluster, 4 cluster, 5 cluster, across these 5 clusters, very similar patterns, right? The first pattern that was the same across all 3 cohorts, which is that about 30% of each cohort has a -1 for all the covariates, which means that the covariates fell under the ASDM threshold everywhere across all of the regions. This was number 1, and this was across the ALI, GLP-1, and DPP4 cohorts. Number 2 was that about 5 to 20% of the covariates were available in North American cohorts, but they were not available anywhere else, or they were just straight up missing. Number 3 was that there was actually a chunk that was interesting, which was they were missing in every other region except APAC cohorts, all of the APAC cohorts, which I felt was interesting to see because I wasn't expecting that. I was expecting this, which was it was available in North America, but not everywhere else. But it was interesting to see that it was available there was some stuff available in APAC, but not available in EU as far as covariates go. Just a quick visualization of availability. I don't think this is really contributing to the conversation, but it's just a visualization of how it works. So this again is the individual cohort, the second cohort, and the third cohort. Each line is representing the likelihood of that covariate having data in the database. The darker the line, the more data that covariate has. This left chunk is North America. This one in the middle is APAC, ANZ. This middle is APAC. And then this one is EU. So you can see here that APAC has this chunk where it has data that nobody else has. And then North America has this data and some of this data that nobody else really has as well. And then it has some data here that, again, nobody else has. And this is sort of replicated. I'm sorry, the covariates are not in the same order. So the patterns are kind of similar. They're just not in the same order. So this and this are pretty much the same set of covariates, and this also. But we can look at that a little bit closely. So I tried to replicate that in the fluoroquinolone study. I only did it for the 2023 SOS challenge because I tried to do it for the bigger and proper fluoroquinolone study, and I couldn't download the Excel sheets because I think the Shiny just gave up on me. Maybe because the data and information was too big. So I did my best with the smaller version. 9 databases, 8 of them were North America, 1 of it was from Japan. Yay, Japan. Thank you again. And this study was trying to assess the risk of aortic aneurysm or aortic dissection following the use of fluoroquinolones. I didn't really have the diagnostics info for JMDC, so we couldn't quite compare in this case. And then, so I was mostly comparing like the cohort counts. And once again, Japan was very small. North America is huge. But anyway, I just tried to run the cluster again just to see what it showed up. It was partially replicating the pattern. So it was finding that about 56 to 60% of the covariates were -1 across all DBs. So earlier, my pattern found 5 to 20%. This was finding 56 to 60%. Again, cohort size was limited for this one. I can't confirm that this is replicated across all the regions, but this was across all of the DBs. The rate of missingness for covariates was slightly higher in Japan cohorts than North America for the 3 out of 4 relevant cohorts. I did try with a bigger study and I couldn't download it. I probably will need a proper study package and then to beg Jack and Nicole to like run it on their server to see if this works. But it is, I think, interesting to me that at least some of the patterns were replicated in the smaller study, and it's sort of giving me like a suspicion that at least I should run it on a couple more studies just to really validate like are my suspicions, are our suspicions true or not true, right? So what does all of this mean? So we're going to summarize. The first is the most obvious, which is that many global network studies are centered around North American data because of the sheer and overwhelming size, before diagnostics and after diagnostics. The second is that it seems that regional cohorts are failing from 2 aspects, covariate balance and empirical equipoise. They're totally passing in terms of ease. We're not worried about that. And the third is that when we're looking at the covariate balance, at least a quick analysis from GLP-1 and the fluoroquinolone seems to support some patterns of missingness. In terms of next steps, again, I need some more exploration, some more of an understanding. Please, somebody who understands the statistics, come and talk to me about it because I barely know how to interpret what I'm looking at. We want to look at the ease. We want to look at the negative control outcomes. We want to do the same covariate balance on more studies if possible. We finally need to firm up the protocol after more of this first step exploration. And then I probably would like some access to databases for initial exploration of other studies. And then, yes, more methodological and statistical validation. So yes, we are recruiting 1 staff expert and at least one. So not just one, but at least one, please. 1 big project data owner who has finished their project, has access to database, has multiple regions in the projects before and after diagnostics. And that is the end of my sharing. Again, I understand it's a little bit messy. I'm happy to go back into any slides to try and explain everything one by one and to try and clean up the methodology as we go. And from here on out, so thank you so much for taking some time with me on this very messy exploratory journey. I would be happy to open up the floor and go back to whatever it is we need to discuss for this study. And if anybody has any comments on how I've been doing it, I will be happy to take critique. Thank you. Yay, thank you.
Yeah. Thanks, Evelyn. I think very well presented. Maybe I'll start off with a question about the databases, right? So yeah, we do see the challenges, right? We do need a good number of databases to draw good conclusions. Have you approached the OHDSI Evidence Network to see if there could be databases that you can tap upon?
Briefly, yes. But in effect, if we wanted to do this, obviously, then I would need to come together to really form up the data package. So I would still need to do that pipeline. I think a lot of people were interested in this study just because it would make, again, the regional studies comparatively more effective compared to global studies. So the TLDR is yes, but still need study package.
Yeah, and I think a protocol as well, because I think they will need to assess a protocol, and then they'll be able to link you up with
Correct.
partners. They'll be able to work with you. I think that could be a good way to start utilizing our Odyssey Evidence Network as well.
Yeah.
Yeah. Okay.
Yeah.
Over to the floor. More questions. Song? Yeah.
Hey, Evelyn,
Hey,
can you hear me?
Yeah.
Is it noisy outside? Do you hear
For
any?
you, yeah, but I can still hear you. It's all good.
Let me step out. Right. Evelyn, thanks for driving this effort. It's great. You're taking on a lot from both a Odyssey knowledge perspective and also looking at multiple study perspectives, right? So both from a depth and volume perspective, I think you're taking a lot. So kudos to that. Can you go to slide 32?
32, 32, 32, 32. This one?
Yeah. So I have my personal interpretations for some of your slides that you presented, but when I'm feeling more confident, so maybe we can discuss this one, right? So you've basically looked at among the initial population of GLP and DPP4, you've looked at how many percentage of those initial populations got matched, right?
Yeah. Yeah.
So just on that, Evelyn, what was so this is more dependent on the matching ratio you chose between the two cohorts. And I don't think it really gives off any signal. This is more just, I don't know what you've intended with looking at the percentages being matched. Because if you choose to do a one-to-one matching, despite the fact that the DPP4 cohorts generally have a lot more patients, the matching rate would be lower because you're going to be matching to the GLP-1 cohorts that have smaller patients, right? Yeah. So I don't think the slide gives off any signal, but again, I'm open to any other perspectives from other people in the call today right now. So that's just one point I wanted to point out. In terms of, so for example, you understand what I'm trying to say, right, Evelyn? So you're saying in some of the cohorts, the percentage matched for DPP4 is much lower than the GLP-1 cohort. I'm just saying this is caused by the fact that you're matching on a lower ratio. So if you chose to do a ratio of 1:4, the percentage is naturally going to get larger. Does that make sense?
Yeah, I think that definitely does make sense. The reason why I looked at this and I slapped it on here because it was interesting, and obviously, as you said, everybody has their own explanations, wasn't necessarily because the DPP4 is different from GLP-1. It was that the DPP4 and GLP-1 percentages for the APAC cohort was different from the EU and the North American cohorts, kind of. And as I mentioned, I just don't really know how to interpret that. But the way I thought about it was like, okay, I think we just have fewer GLP-1 users in APAC right now, and that may interpret the results. But I opened it up to the floor just because I wanted to see if anybody else had any other interpretations of this. I'm sure there's other ways of looking at it and many more ways of like doing, again, more statistical analysis. But that was just an idea, which was that like, okay, the question that we were asking was along the line of GLP-1s, and GLP-1s are obviously being used in Asia, but it is still true that our cohorts, our databases have less of that data. And that may influence maybe how we work with some of the databases. I'm not very, very sure about if it does or not yet. Yeah, so.
Yeah, so that's one aspect I just wanted to discuss. Happy for anybody else to chime in on their perspectives. Personally, I don't think this slide gives off much insights aside from the fact that depending on how many people you want to match on, you're going to end up with a lower or higher prevalence from either of the cohorts. Yeah, but that was the first perspective, Evelyn. The second one around the covariate balance, right? I think this also sort of is dependent on the cohort size, right? Because essentially what covariate balance is, so the counts you're getting is among the patients of the cohort, how many people have the covariates and how many people got matched through the balancing of those covariates, right? So again, this is also outside, or I would say outside of my expertise, and I'm pretty sure there's more knowledgeable people here in the call as well who know more around how the covariates get balanced in the OHDSI packages. But my knowledge, or my limited knowledge, is that the covariate balance is, again, not the interpretations you see from the covariate balance results can't be extrapolated to the overall general database itself.
Yeah.
I guess is what I'm trying to say. It's very study specific, right?
Yeah,
So
correct.
you're looking at the of DPP4 patients and GLP patients, but how can we extrapolate that to a overall general population of that specific region is another statistical or methodological question that we should be thinking about.
Yeah, so actually, originally, when I was looking at doing this, obviously the first thing that I thought of was, okay, I should probably do a protocol. But as you said, each study is sort of different, and each study is looking at different things, and therefore the prevalence incidence counts of each study are going to be different, and that's going to be more of a clinically related question mark than it is a statistically related question mark. And sort of up until this point, the reason why I've resisted, like sort of semi-resisted having like a full-fledged protocol was because I felt that at least we needed to look at the study as an entirety, including the question and what it's asking about, and the public health related assumptions related to the clinical question, not just the statistical availability of the database. And so, yeah, that was actually one of the things that we recognized, and that was why I wanted to look at more studies, because it was like, okay, this is definitely a GLP-1 study specific pattern. And then I would have to rephrase the question or the pattern into other studies to see if any of these patterns are replicated. But it is still true that those patterns are they're going to be different, maybe pharmaceutically. So the patterns may be different, but they may not be the same. We may just see a bunch of different patterns in regional cohorts that we don't see in North American cohorts, but those patterns may still not be the same. So I struggled. And I'm still struggling with, like, what am I supposed to do to phrase this protocol, and what am I supposed to do with it? Yeah, we can generalize it, but yeah, I'm still struggling with that. So yeah.
I can relate to your struggle, Evelyn, because it's a good concept, a good question you have. I guess from a methodological perspective, how do we do this in a structured or a statistically or methodologically acceptable way is also something that's beyond my expertise, like yourself. So yeah. I think this, like, for example, right, Evelyn, you said some covariates were observed in North America only, and vice versa. Some were only observed in the APAC region, right? So this is probably, like, from my guess, this is probably caused by the fact that some drugs are more frequently used in the APAC side of the world versus the North American side of the world, right? And vice versa as well, right? So it's a good question. I think it's really hard to frame it into something that's generalizable across multiple multiple studies, even from a regional difference perspective. But yeah, I guess I don't have a solution for you either. I'm just making observations based on your initial explorations, which I think is a great effort and a great initial starting point. I just think we need more sort of experts who are more knowledgeable in this field to help and guide you in what be the best way forward. But yeah, Evelyn, like, again, I'm not here to challenge you. I'm just here to give you.
Please do.
Share my understanding of what these results mean. So I hope my comments were not offensive in any way.
No, not at all. No, I completely agree with you. And I was sort of almost ready to delve into this like a qualitative study, almost without, because I was like, I don't know how to generalize this. Anyway, so Cynthia and Jack have their hands up. So Cynthia, please.
Yeah. I'll shut up now.
Yeah. So I think it's really good you're trying to dig into why the Asian cohorts and the European cohorts failed a protocol that was supposed to be for a global network. And so I think the point that Sung made, like, is there any reason that it has to be a one-to-one match? Like, since your total number of patients in each of those cohorts looks like a ratio about 1 to 4 or 1 to 5, can you just do that so that there's more of the numbers that the ratio is gets closer to the same number for each database? Is there any reason you couldn't do that?
That is a great statistical question that I do not have the answer to. Does anybody else have the answer to that? Because I don't know.
General practice, you do a higher ratio, matching ratio, if the population is available. So, yeah, but I heard somebody else speak. Please.
Oh yeah, sorry, it's Jack. I've just got my camera off because my internet's a bit dodgy. I I just wanted to tack on to what Cynthia has said, and perhaps Song as well, is, we have these thresholds that, give us nice, reproducible and reliable results that can then be used, in clinical practice and whatnot. I'm wondering whether with our APAC databases and the information that we've got, whether a study like this might help us identify whether that we need to have another look at what thresholds are applicable in our context compared to perhaps the Northern American databases. And I was wondering whether maybe something like this kind of work could be used as a way to develop perhaps best practice guidelines for conducting perhaps APAC studies, which, yeah, it's we've got nicely on the slide here, as Evelyn's put it. So I think that might be the angle to take rather than to, yeah, sort of be doing too much of a comparison, I think.
Yeah. I want to pass it around. Sorry, back to Chungsu.
Hey, this is Chungsu from Korea. Maybe I can share some possible explanation why the number of patients of GLP-1RA versus DPP-4 inhibitor is so different from the Korean database. I thought it was due to the national health insurance coverage. So because the semaglutide and tirzepatide, which are very popular in these days, but were not covered by a national insurance at that period. So SEMA just had recently been covered by national health insurance, and that's the one of the possible explanation of that differences. And then the cohort for GLP-1RA and the DPP-4 inhibitor also may differ due to the combination product, because many of GLP-1RA products are combined with insulin. So maybe physicians are more likely to prescribe that GLP-1RA to more severe patients. And the third one is that because the GLP-1R have some indication to the cardiovascular disease, so they are very highly likely to be used in the patient with established cardiovascular disease. So these may have cause some differences between the two cohorts. And I'd like to ask Evelyn, did you have a chance to reach out to Legend type 2 diabetes team to explore some more pattern between the GLP-1RA versus DPP-4 or versus other agents?
So not yet on the Legend T2DM. That was actually something that Nicole brought up as well yesterday, and it made more sense. And that was why on the last slide, I will say, okay, I need some better databases. And also it's been abundantly clear that I can't do the manual downloading of Excel sheets from Shiny apps anymore, which means I need to go back and develop a proper R package to deploy. But yes, I think that makes a lot more sense. But I think your point is also exactly why I was like, okay, this might be sort of a combination quantitative and qualitative study. And the question was, and sort of what I was trying to look at was, okay, there are obviously some database specific and then country specific considerations, and then regional, and then possibly regional and non-American type characterization. And my interest, at least as part of this study, was in trying to suss out, okay, we're going to find some patterns. Which patterns are specific to regions, which patterns are specific to possibly countries, and which patterns may be very specific to each individual database. And what does that possibly mean for, as Jack said, maybe developing new guidelines or new frameworks. So Korea, for instance, it has these additional insurance-related considerations that may affect the cohort counts. Like, what would that mean? Because those are actually very similar to some of what we have in Singapore as well. So if it was just Korea, I'd be like, okay, this is just Korea. But if I'm seeing that in Singapore as well, then now I have to think about are we going to be able to extrapolate that to the rest of APAC, or at least some countries in APAC, and what that means for working with our databases. Thank you so much, Chunsu. But sorry, Cynthia, before I round back to you, can I just give it to Nicole real quick, because she just got here. Thank you.
Before
Yes,
before that, maybe I can volunteer that work because I have an access to the Legend T2T server. So
yes, please. Thank you so much. I will love you for that. I'm sick of working with Excel sheets. Nicole?
Hi, yeah, thanks for that. And I'm sorry I'm late, but Evelyn and I went through this yesterday, so I'm aware of all the results. So great work, Evelyn. One of the things I think we need to really consider when we're doing this work is, what are the design issues that are specific to the design and agnostic to the database we're working in. So Cynthia, back to your comment about, should we be matching 1 to 4 or 1 to 1 or that kind of thing? All of that is very much a design issue. So that it doesn't matter what database you're in, what are the best practices for the, implementing the methodologies. But I think what we're really wanting to get here is like, what is it that our approaches don't take into consideration when we're doing international studies across different regions? And we already sort of talked about some of that, what are the different prescribing patterns, and, what are the different population characteristics that we don't account for when we're doing our propensity scores and so on. So I think maybe, Evelyn, this has been a good conversation, at least for me, to think in my head, well, how would we design a systematic evaluation? We really need to think about what are the things that could impact on the application of our analytics when we're doing international studies, right? And one of the big critical ones, I think, is the measurement of the negative control outcomes, because that's, again, a very discrete set of outcomes that we can really investigate across different countries. Like, can we even measure the negative control outcomes? Do they even exist? And if they don't exist, and we don't get a true set of negative control outcomes, then we're never going to pass the EASE score. And if we don't ever pass the EASE score, it doesn't matter what, the propensity score is doing for us in terms of covariate balance. So I think there's some things based on this conversation. I can see a bit of a way forward in where we would go in the next steps to evaluate this. So it's been really useful.
Yeah, I think already that we're sort of starting to define the areas of evaluation. The first is the main framework and the main statistical ability. The second is the database characterization. The third is the design of the study itself and how that is relating to the frameworks. And the fourth is maybe the contextual information. And then the fifth may be just a qualitative, like a sort of a manual evaluation of what's going on outside of statistical associations and evaluations. So I think all of that is sort of distinguishing itself reasonably well, maybe. And that will probably help shape up the question than the protocol. And I will round it back to Cynthia.
Thanks. Okay, so can you go to the slide where you had very colorful like columns with lines where each covariate? Can you go to that one? Nope. Another one. Let's go. Yeah, that one. Right. So are the covariates that are used to for propensity scoring defined in the protocol, or is it more like a methodology, like look for covariates that have at least X number of subjects and in both, in all the cohorts, and then pick like the top, I don't know, how many covariates are looked at for propensity scoring? Do you know?
I don't know. I do know that it uses feature extraction. I don't have off the top of my, yeah, Nicole can better answer this maybe.
Oh, okay.
Yeah, from depending on what one you're looking at, and it's pretty much always a large scale propensity score. So Cynthia, it's a data driven large model. Changsu can chime in here, but there's no kind of manual curation of the list. It's thousands and thousands of covariates.
And so that can be a different list for every database that this is run in?
Well, it's not a different list, it's the same list, but the different databases may have data for some but not all of those covariates, depending on the utilization or the prevalence of those things across the databases. So
so I'm just thinking that, like, go back to that figure. If you were to just do like a feature extraction on like the Asian databases, you probably would come up with a really different set of covariates. And so, like, just taking a step back in methodology, maybe it should just be, for your region, run a feature extraction so that you get, and then test whether you meet the 0.1 threshold for those covariates, rather than taking from a feature extraction that was done on some other database. Does that make sense, Nicole?
Yeah, it makes sense, but that's not really the way that the propensity score is built. It's not like it does a feature extraction on one database and then that propensity score model is then, exported to anywhere else. The propensity scores are all built within their own database and utilized within that context. So, the fact that the propensity score of models may be slightly different in terms of the, the individual covariates that make up that propensity score, that doesn't really matter, because the propensity score itself is the thing that we use, not the model. I see your point, but it's not really the way the large scale propensity scores are created. But having said that, for I think it was the fluoroquinolone study, when we produced table 1 of the covariates, you can actually see where some of the countries are very different in terms of the characteristics of the patients who get drug A or drug B, right? So you can start to do that characterization in your head and understand where things are different across the different countries. But in the end, the application of the propensity score adjusts for all of that within the context of the database and the region you're in. So it doesn't really matter that there's different propensity scores, if that makes sense. But what matters is the overlap between the propensity score distributions in the different regions, and that's the generalizability impact. And we found that with the fluoroquinolone study, where we looked at trimethoprim and something or other. Jack, you'll have to help me say that word.
Spectrum.
The sulfur one. There's quite a different overlap in the propensity score distributions across the Asian databases and the US database. And that in itself is really interesting, because what we're seeing is different preferences for treatments. So it's complex. It's a bit of a complex web.
Well, just because there's that, big chunk of covariates that are existing in the Asian database that are sort of not so prominent in the North American. So like, how do we adjust for that? Or how do we write a methodology that says, okay, like maybe favor the covariates that are more present in the APAC? Is there a way to adjust for that?
I think, Cynthia, so that's definitely a question that we want to answer for later, because as I mentioned, one of the long-term objectives is that, okay, maybe we want to be writing up, if necessary, possible guidelines in terms of addressing it. I think Nicole's point was maybe along the lines of like, okay, we still need to validate whether or not this hypothesis, and we are very much still in like this is a hypothesis type of stage, whether what we're looking at genuinely warrants that adjusted guideline or framework, or if it warrants a different kind of intervention in terms of working with regional databases. And I do agree that we need to look at more studies, more data, more stuff, just to see, what's going to show up. So, after this, especially with the Legend T2DM, I will probably officially start a project to meet every month, every couple of weeks, we'll see. And then we can start having a little bit more of the in-depth discussions. And we'll probably go back and forth and try to maintain a document, just because this is so extensive and so sort of all over the place. And what it means is still very much up in the air. Like, this is basically, I barely cracked the ice on top of the lake. I'm sure there's so much more to get through, and it's gonna take a little bit more work, which again is why I didn't want to do it for this year's APAC symposium. We're probably going to be doing this until next year.
Okay.
Yeah. So yeah, we will definitely have more discussions in relation to this, but yeah, I think we just need to validate the method some more, and either expand it or sort it out. And once we come to an agreement on like, okay, this is genuinely a regional thing, a pattern, a really specific pattern, then we can make the really specific either design changes or framework changes or methodological recommendations for working with maybe regional databases or specific studies, whatever it turns out to be. Okay, I'm gonna run back off to Jack, because I think we've got like 5 minutes left before I let everybody go for lunch.
I just heard you mention about Legend type 2 diabetes study. Would it be worth using the hypertension one as well, just so that you've got kind of different clinical areas?
Yeah, I think I would like to expand into them, but it's just so I think Dr. Chan gave me like a link to the Shiny deploy, and I was playing around with a lot of them. And actually there are not really that many studies with regional involvement, at least on the Shiny. There's probably somewhere that's not on the Shinies, or maybe I'm looking at the Shinies wrong. But I mean, my main interest in like, let me just get whatever studies are available that have regional involvement, and then ideally we'll spread it out across as many different specializations as possible, so that we're not limited to, okay, we're only looking at diabetes. But sort of the primary filter here is like whatever regional data we can have. I know that obviously we had all of the 3 Chinese APAC studies from last year. I don't know if we have any representatives from OHDSI China here. But I would be interested to see if what those studies look like, because I haven't seen, at least for this study or the Legend study, or actually I don't know about the Legend study, but for this study, the fluoroquinolone study, I didn't see any Chinese databases. Obviously there's Taiwanese databases, but those are different. But I would be interested in seeing what that looks like. So basically, give me as much as you can, and we'll see what shows up.
Well, I think in the COVID studies, there was good global representation. You might have to go back to that. And in any case, if the programs are stored in a GitHub, I don't see why. I mean, if you could interest some people to run an old historical one, just to get the results, and then that could contribute to your data for evaluation.
Yeah. So I think basically the next step for this one is just like, okay, whoever is involved, obviously, Dr. Chung Su, etc. I'm just gonna send out an email to everybody that's sort of interested, and we'll have another meeting and probably develop a protocol and or methodology from that, keeping in mind that the methodology is I will probably insist on keeping it sort of half statistical and quantitative and half manual and qualitative, just because the studies are so different and the protocols are so different and the Chinese are so different and everything evolves. So yeah. So that's where we're moving forward from next. We have 3 minutes left. If anybody else who has not spoken up has any like last minute questions, I'm happy to take them before again I let everybody else off to lunch because y'all are very hungry.
Well, can I just say that, I mean, Singapore wasn't in one of your Asian databases, and can you just tell everyone what we're trying to do for Singapore?
Yeah, we're trying to replicate the GLP-1 study for within the Singaporean trust database. I think frankly Mukesh is better at explaining trust than I am, but effectively it's a nationalized database. So we're just trying to replicate it to see. Originally, we were supposed to do the GLP-1 on like a version of the database that I was supposed to have, but of course we lost the data. So we're trying to replicate it in Singapore, and we'll see what shows up in trust and see what happens there. But yeah. Okay, 2 minutes. Last minute questions.
Yeah, thanks, Evelyn. I think we will again like to have more participation in this project.
Yeah.
Be able to get more evidence across Asia Pac. And Evelyn, just a comment earlier when Chung Su said about the insurance aspect, right? I think there's also a regulatory policy component to it. So if we look at Singapore, and you look at the public records HSA, GLP-1 was introduced in 2020. Right? In the US, it dates back to 2005. It was only when there was more value shown in the cardiovascular and obesity treatment that GLP-1 became more widely prescribed. So there's also that angle where you might want to define in your protocol, what is the period you're looking at in terms of, this databases that could help you to answer some of the gaps in the missing GLPs that you see in your databases. Yep.
Yeah, for this specific GLP-1 study, yes, absolutely. For the rest of in relation to the meta study, though, I think that's definitely something to consider, which is something that Song brought up at the start, right? Which is like, okay, yeah, look, it's different countries. Everybody's using the medication differently, but are those patterns replicable across studies? And that's very much not really a statistical point and very much more of a public health or insurance or regulatory type of point, but it still influences the database and still influences the study in a sort of non-quantitative, qualitative, individualized way. So what that means is still sort of a big question mark. Okay, amazing. It is 12 p.m. and I will pass it back to Mukesh and Erwin.
All right, thanks there. All right, I think we're just on time today. And great questions. I think we had a very good almost 30-minute discussion, which hopefully helps Evelyn in driving this project further. And we'll refine this study as we go forward together as a community. Otherwise, we'll tune in 2 weeks' time for the community call. All right, thanks, everyone.
Thanks, everybody. Bye.
Thanks, everyone. Happy weekend.
Happy weekend.
Happy Easter.
Happy Easter.